It's just I just need to share the screen to ask them to to fill up survey later on as well. Right. Okay. I think we might as well start. Okay. Hello, good afternoon, everyone. Welcome to the sixth series of BRC online research seminar series. Today, we are privileged to have both Professor Heidi Siddle, who is a consultant podiatrist, and also Professor David Russell, consultant vascular surgeon, and both of them are NIHR committee panel. So they'll be able to enlighten us pertaining to how to develop a successful grant application. So before we start with the program, so a few house rules, just letting you know that we have set the room that everyone is muted automatically. So please don't unmute yourself. And we will have a question and answer session at the end of the session. So if you do have any questions, so please put in the chat so that I can read them all out at the end of the session. Just also to let you know that the session is recorded and recordings will be available at our BRC YouTube channel. I'm also going to share this as well. So if you do have your, Yep. So basically, if you do have your phone, so this is the QR code for feedback survey. So we want to know from you all what went very well, what could be improved, and also what are the topics that you want us to include in the next series. So if you don't have any phone on you, we will also circulate this after the meeting as well. So this will be really helpful. And once you fill the survey, it should only take about 2 minutes. You will automatically get an electronic certificate as well. So that will be quite useful. Without further ado, so I will invite Professor Heidi Siddle to kickstart the program today.
Brilliant. Thanks very much, Yaz. I'm just going to. Are we sharing? Brilliant.
Can you see the screen okay?
Yes.
Brilliant. Okay. Lovely. That's a good start. So yeah, good afternoon, everyone. My name's Heidi Siddle. And as Yaz said, I am a podiatrist by clinical training and have a role as a consultant podiatrist in Leeds teaching hospitals alongside my role as Professor of Musculoskeletal Health at the University of Leeds. So we're going to talk about sort of developing a fellowship application from both myself and Dave have been awardees of fellowships in the past, but are both panel members now of the doctoral fellowship committee. So hopefully, as both recipients and as panel members, we can share some of our insights of what we've experienced on both sides that will be helpful to you in the future. So I'm going to, brilliant. No, I'm not going to move the screen. Brilliant. So I'm going to talk very much from a personal perspective around developing a fellowship application and about how you sort of think about the person, the project and the place that will enable you to develop a successful application. Professor Tony Redmond has been my senior supervisor for the majority of my academic career. And if anybody's met him before or had any involvement with him, you'll be very familiar with these two question statements, and they still resound with me now and underpin what I do in terms of how I develop and what I want to do in the future. So what do you want to be king or queen of? And that's really important when you're thinking about the person that's going to be applying for their award and what you want to be at the end of that, because this is a personal development training award. And for me, certainly surrounding myself with good people has definitely led to good things happening. And so hopefully if you can do the same by seeking those opportunities to work with appropriate people, and whether that's people who are junior or senior to you, then good things will definitely happen. So where did I start? Well, there was essentially an invasion of foot academics in Leeds. Professor Tony Redmond, who I just talked about, and also Professor Jim Woodburn and Philip Halliwell. Philip Halliwell is a rheumatologist, and both Tony and Jim are academic podiatrists. Many of you may not have had the opportunity to work with podiatrists, let alone meet sort of academic podiatrists. We're probably a small breed and have been quite a unique breed in Leeds, but have now the opportunities that we've had as podiatrists have certainly been able to help other both medical and non-medical clinicians in our field. So I was very much a clinician and very quickly influenced into a clinical academic role by this team. So like I said, I began my role as a clinical podiatrist in Leeds in 2000. I qualified as a podiatrist in 98 and had a couple of jobs in a clinical setting. But very much was focused on developing myself personally as a clinician and hadn't really had much experience of working with academics other than my undergraduate degree, let alone thinking about a clinical academic career. And I had the opportunity, I guess it would be something along the lines of a PCAF or a pre-application support award now, to undertake the role as a clinical coordinator for an RCT based here in Leeds, and did that for a couple of years part-time whilst still continuing to develop as a clinician. And then I'm sure, as you've probably experienced already yourselves, is a lot of things happen by coincidence or by accident, but usually there is a plan behind that. And I fell into essentially doing a master's in advancing clinical practice, which I did part-time whilst working essentially full-time clinical, and completed that at the University of Huddersfield. And was very fortunate with the outcomes of that project that I did for my dissertation, led to a national award and evidence that now underpins the NICE guidelines for rheumatoid arthritis. And that was working with the team. So already I'd started to build a CV that was in the area of interest that I had clinically, but was starting to answer some of those clinical questions through sort of early research funding and activity. I had the opportunity to apply for an Arthritis Research UK Allied Health Professional Training Fellowship, and that's very similar to what is now known as what in the new phase is called the doctoral fellowships, funded by NIHR, the previous clinical doctoral research fellowships on the integrated clinical academic programme. And that was before really any sort of non-medical clinicians were applying for NIHR funding, but it was very similar. And I had the opportunity to study from a PhD part-time or full-time, and I undertook that part-time whilst maintaining my clinical position. And that was the really attractive component for me, that I was able to start to develop my clinical and academic skills at the same time. And whilst that opportunity arose as well, I had the opportunity to engage with other clinical researchers at the university, and that was through being a co-applicant on an NIHR Research for Patient Benefit in 2006 to 7, when we were successful in 2007, and that was the very first round of the RFPBs. And so I learned lots through the opportunity to contribute to another application led by senior academics, but also then had the opportunity to work with another clinical researcher who was undertaking her PhD. So my role there was sort of engaging in research activity through my clinical role. And as you can see, that led to a couple of publications that have underpinned some of the work I've done since. So continuing on sort of how you develop as a person, that my PhD was covered over 5 years. And sometimes at the start of our journey, it can seem quite daunting, but I think it's important to remember that we're all doing this usually alongside many other things as well, both in a clinical environment, but also in our home lives. And just to reassure you, you can continue to develop as a clinical academic whilst getting married, having 2 children, and continuing with what you like to do outside of work as well. So it's not all good news. I went from my PhD fellowship, it had all been very successful to this point, and then I got to the point of sort of how do I take it to the next stage, and I applied for a clinical lectureship whilst it was actually sort of towards the end of my maternity leave before I returned back to work. And unfortunately, I was unsuccessful, and I would, most of my colleagues who have gone on the clinical academic journey have been unsuccessful, whether it's in a fellowship or grants. And it feels like the most horrendous time point when you get that rejection. I've had plenty of experience now of having rejection, so you take it in your stride. But the feedback is often really useful. And this was the feedback that I received, and hopefully you might find it useful when you're thinking about your application. They were very complimentary in terms of being a strong candidate and excellent potential, but they did note concerns with other parts of my sort of CV, essentially, of regarding sort of my project particularly, and quality of elements of the proposed research, particularly its focused. We're often trying to solve a whole world problem in one go, and that can be quite difficult, particularly if you're not focusing, sort of on a specifically an RCT where you're looking at the effects of maybe one drug versus another, or one drug versus placebo. We're often involved with many complex interventions, and so trying to get that focus is really important. The potential to have an impact on public and patient healthcare within 5 years. I spend a lot of time now talking to other people about what will be the impact, how are you going to impact what you do, or the care that you provide within the next 5 years. My application was too ambitious within the timescale. Once you start, once you've completed your PhD, it's a very large program of work to do that. But actually, beyond that, and particularly if you're developing a fellowship application, that actually sometimes you need to have time to develop the rest of your skills, and not only just to undertake the research application. Otherwise, you're unlikely to be successful with the research if it is overambitious. And so I took on board this feedback and went back for a second time, and was luckily successful the second time. At the same time of getting my NIHR clinical lectureship, during that time, I was continuing to develop as a clinician, and was appointed as a consultant podiatrist within the trust, and also had the opportunity to apply for an honorary clinical associate professor title at the University of Leeds, and was successful with that in the first round that they introduced for non-medical clinicians. So continuing on my journey, very much at that part, it was focused around me and developing as a person. But as we develop as a person ourselves, it's about giving some of that back, and working alongside other people to develop their role as well. Because as you start to develop, they want to, people like funding bodies like NIHR want to see that you're actually starting to support other people and bring other people along that journey with you, in order to build an NIHR family of successful clinical academics, successful researchers. And so I took on the role of R&I lead in the Adult Therapies Clinical Service Unit that I'm based within in the Trust, and also worked very closely with the newly appointed lead nurse for research and innovation to help build research capacity for non-medical clinicians within the Trust. We've moved away from using the term non-medical clinicians to healthcare professionals, so forgive me for using that term, but it was a term that we advocated for a very long time. But also my own clinical academic leadership, both locally, nationally and internationally, was really important. And I became involved with the European Organisation for Rheumatology to help develop competencies for health professionals using ultrasound. This was my clinical area at the time, and was very much focused around my clinical lectureship and the work that I was doing. There was a new group developed within the Royal College of Podiatry for podiatrists using ultrasound, and I had the opportunity to lead that group, and also was invited to become the allied health professional representative for the NICE guidelines for rheumatoid arthritis. So it's about sort of as you develop yourself in a national role, it's also about pushing those boundaries and thinking about how you might develop not only nationally, but internationally as well as you move beyond and start to develop as an independent clinical academic and independent researcher. I've talked lots about the person, and the place for me has been very important as well. The place that you develop yourself as a clinical academic certainly has been very important for me, and having the opportunity for collaborations both locally, nationally and internationally, and thinking about that in your field all the time. Thinking about the clinical and academic environment that you're working in, and mine has been very much based around Leeds Teaching Hospitals and the University of Leeds. But some of the roles that I've taken on in terms of research supervisor now has been working with people who are in other trusts locally, regionally, and more nationally. So giving people those opportunities to develop new roles. And that might not be, that might be necessarily within your own clinical area, such as rheumatology, where I've been, but also looking to other disciplines. And that's taken me sort of to look for experienced people in other areas, such as cancer, who are have done some of the same things that we've done in the clinical area. And I'll talk a little bit more about that in just a moment. The place has been very important, and I was at sort of fairly new in the development of non-medical clinicians undertaking research, and it's been really important that not only do we try and develop people around us, but we think about the organisation and those people who are there to support us, and sort of in a clinical management role, and so we have been thinking about the landscape and how we can actually develop clinical academics in their job roles and in their job descriptions moving forwards. Because quite often we can have all of these skills, but if they're not needed within the roles that we're doing previously, then that can make it quite difficult to come back into our clinical academic roles once we return from, say, having some time out to do a fellowship. And so I was involved with helping to sort of transform the landscape for non-medical clinical academics, and have worked closely with HR, both in the trust and the university, to extend what was a memorandum of understanding previously just for medics and dentists, to actually extend that to all healthcare professionals, to hopefully enable clinical academic joint appointments across the trust and the university. And in 2018, I was appointed to a joint appointment, and my recent promotion to chair was as a joint appointment across the trust and university. But also to been part of a research implementation group to ensure that the continued success of these, and that we're always thinking about how we can evolve, and now have a couple of members within my team at the University of Leeds who are now in joint clinical academic roles as well. And finally, I'm just going to talk a little bit about the project and how you start to think about that. And I couldn't possibly sort of cover every single project that you might be thinking about as potential clinical academics, as potential researchers. But just some of the tips that I would share along that journey is that obviously your research does need to be novel, but we need to make sure we're avoiding sort of research waste. And so sometimes the novelty can be too far out of the current scope, that actually it's going to take a long time to come back in and to be implementable in practice. And obviously we don't want to be repeating what somebody else has done, and therefore it's important that we do that work before we start. Once we've got a clinical research question, what has been done before, and how do we ensure we're not repeating that? Link with a research agenda. We're all probably quite familiar with things like James Lind Alliance priorities. What's important to the patients, the research, the clinical community? Link your clinical question to that. Utilise local infrastructure. What's available locally? Do you need to? Is there a trials unit? Is there other methodologies, other methodologists that will be really helpful and beneficial to your project. We talked a little bit already about the impact, or whether it's implementable within 5 years. Any project that you're thinking about for a fellowship needs to be sort of able to help you develop as a clinician as well as an academic. And I'll talk a little bit about training plans in a moment. And they have to be ambitious to meet the requirements of a PhD or the next level, but not unachievable. And I think I alluded to that earlier, particularly with my unsuccessful application. And it has to be your interest and not someone else's. And I think that's probably a really interesting point. Dave might mention this a little bit later, but sometimes we see when we review applications, we see a fantastic application and we see sort of lots of evidence of why this might be a good application. And then the person gets invited to interview and you start to unpick some of what you see in the application. And we can sometimes clearly see that this is not always driven by the applicant. It's driven by somebody else and maybe not their primary interest. You can really see an applicant who is at the heart of their application and is driven by what they want to do. So just be careful with that. I'm just going to quickly share my last fellowship application with you, just to give you sort of an idea about what it looked like and the type of team that I brought together. So this was around improving the identification of inflammatory arthritis in primary care. And typically you'll see 2 or 3 work streams in a fellowship application. And usually that's working with some current infrastructure. And as you can see, I worked closely with the BRC, the Diagnostics Cooperative, and sort of local clinical research networks in our area. And 3 very different work streams that work stream 1 and work stream 2 that led very nicely onto work stream 3. Bringing the team together, this is my amazing team that were able to support me during my sort of the development of my application. And you can see they're people from very different sort of both clinical and academic areas. So Professor Paul Emery is a rheumatologist and has led the clinical academic team here in Leeds. Dr. Louise Warburton is a GP with a special interest in rheumatology, and that was really important when I was doing, very much embedded in a secondary care environment, but what I was doing will have a strong impact on what happens in primary care. So it's important to have both secondary and primary care input. My second work stream was around health economics and how clinically and cost effective what I'm doing in the future will be. And therefore it was important to have somebody like Chris Boyke on board right from the start. Professor Sue Richards is a methodologist whose research has always been focused in primary care. And I alluded to a little bit earlier about sort of taking expertise from other specialities. And Professor Richard Neal was a GP who was specialising in diagnosis of cancer, early cancer in primary care, and therefore was able to share lots of the early identification of cancer and what they've done both through research and bring that to the world of rheumatology. So that was the team that supported me. And then you have your team on the ground that help you during the sort of each of those work streams. And I've worked very closely here. You can see there's a whole raft of different methodologies and clinicians who have supported me during that to help me work through my work streams to support the work that I've been doing, but also to provide guidance where I'm learning a new area of statistical methods, different areas of rheumatology practice, health economics, and some qualitative research as well. And that's just going to lead me into sort of thinking about your clinical academic training. One size doesn't fit all, and certainly the more imaginative your clinical academic training programme is, the more exciting it will be for you. And for us as reviewers, it's nice to see something fresh and new ideas about how you develop as both a clinician and an academic. But although it's an opportunity, it shouldn't be an exhaustive list of your lifetime ambitions to try and fulfill. We often see very extensive training programs that literally, if you were able to complete everything, you probably wouldn't have time to do your PhD. So be very much aware of that. This is important for your development, and you are on a trajectory to be a world-leading expert, but your training program at that time is unlikely to lead you straight directly to that. So be aware of that. And look outside of your organisation and your profession for both your clinical training and your academic training. Certainly as a podiatrist that started out as what was known as a basic grade podiatrist in 98, I certainly didn't think that I would be undertaking health economic research or qualitative research, let alone some of the other things that I've undertaken. So, I've extended my clinical and academic skills. And just coming towards the end, the clinical and academic training programme, that we like to see a timetable and milestones for completing that training program. And as I alluded to, that needs to be realistic within the time frame that you have. And it's good to see, for us to see as reviewers, how much of that time it takes up during your proposed fellowship. The justification for the training proposed, we see some very expensive training proposed, and that's fine as long as it's justified. Some things are very costly, but are very important. Other things are timely and take up a lot of time, but are also very important. So it's about getting that balance right. And do you always need to go on a course? There are lots of other ways about thinking about your training. Can your supervisors or mentors provide trainings? Are there placements that you can undertake with experts in the field? So just be a little bit imaginative with what you like. So just to summarise my part, where I hope that I've demonstrated the ability to go from a full-time clinician to a clinical academic leader. And these are sort of the 4 parts of my jigsaw that have come together and I hope will be useful for you. I've embedded my research focus in existing research infrastructure, and that's really important, certainly when you're starting out. You're going to need that support. And that's within the section of clinical biomechanics and physical medicine in the Leeds Institute of Rheumatic and Musculoskeletal Medicine. I've collaborated lots with other disciplines, and that's extended to medical colleagues, non-medical colleagues, engineers, and lots of other people in order to develop myself and to develop my portfolio of research. I've used my research experience to expand into other clinical research areas. I'm very much come from a background of rheumatology, but have used some of my skills within rheumatology to work with colleagues like Dave here in diabetes and some of my other colleagues in orthopedics as just an example of some of those. And for me, it's been really important to not only develop myself, but to increase research capacity within others as well. And that's through sort of organisational changes, but also just been directly supporting others. And hopefully some of the experiences I've been able to share with you today have come from the both pre-doctoral, doctoral and postdoctoral applications that I've supported during the last sort of 15 years. So I'm going to finish there, and I'm going to hand over to Dave now, who will talk much more about sort of from a panel perspective. Thanks, Dave.
Thanks, Heidi. So hello, everyone. So I'm going to talk to you now about how we look at things from a funding panel perspective. And I think it's generally true across all the funding panels in NIHR, because they very much follow the same scheme, but this is largely looking at doctoral research fellowships. I wanted to start just by showing that you don't have to go through an academic route and sort of start right at the beginning of NIHR in order to progress. So I came into clinical academia quite late in my career. I'm old. I graduated in 1997, and did my house officer, as it was then, and basic surgical training posts within Yorkshire and Humber. I then, as most surgeons did at that time, did an MD, because almost a prerequisite at that time to get onto a surgical training scheme, and mine was looking at carotid plaques. So I did some basic science, looking at neovascularization within carotid plaques, but also developed some ultrasound tools for assessment of carotid stenoses. And from there, I went on to higher surgical training within the NHS. And my first real academic post was whilst I was away doing a senior vascular fellowship in Adelaide, where I became a lecturer at Flinders University in Adelaide. And I was appointed here in Leeds in 2010 as a consultant vascular surgeon, really with a remit of developing the vascular side of a diabetic foot service. So on my appointment in April 2010, I had 8 peer-reviewed publications. I had one European Society travel grant of €1,000. And there were 3 further papers that we submitted from work we'd done in Adelaide. So I think you could probably safely say that I wasn't a barnstorming academic at that time, but I was an early adopter of new techniques, and diabetic foot was a relatively evidence-free clinical area, and there was a lot of clinical need really to drive a translational and clinical research portfolio. So over the last 10 years, I've again been lucky to have some fantastic mentorship, particularly within the clinical trials unit here in Leeds, and some really good clinical colleagues. We've managed to establish a national clinical academic group in diabetic foot, and through that, through Leeds, we've been able to get funding for 2 HTA grants, where I was a chief investigator and one as a co-applicant. And in 2020, I was awarded an advanced fellowship again to look at aspects of diabetic foot disease. So I do know what it's like applying for fellowships on both sides of the fence. We've then developed a work stream within the BRC, and for the last 2 years, in light of that work, I've sat on the NIHR Doctoral Research Fellowship panel. So I'm really talking you today based on my experience of sitting on that panel and looking at how we assess applications from the other side. There's a fairly simple process to the NIHR fellowship application. So for doctoral research fellowships, you fill in your application, and that's initially checked for eligibility by the Academy Programme Managers. So if your application is out of scope, then it gets declined at that point and doesn't go on for peer review. Otherwise, there's about 45 people who are within the DRF application or fellowship selection panel, and we each get sent out somewhere between 5 and 10, depending on the number of applications in that round, applications to internally peer review. So it's important to realise that for most people, most people providing the peer review will almost certainly not be a clinical expert in your area, and also may not know some of the methodology that you're adopting, but usually will either have some clinical knowledge of the area or be an expert in that methodology. And that includes statisticians, methodologists, health economists, for example, as well as qualitative and quantitative researchers. So it's really important when you're highlighting your project, for example, that you really go thoroughly through the reasons or the backgrounds for the clinical needs, and also give us a strong story of why your research is relevant. The exception to that is for the advanced fellowships where they then go out for external peer review as well. And obviously you will get peer reviewers then who are very au fait with the research in that clinical area. And if you're successful in going through that peer review process, you're then invited for interview. So how do we assess the application? Well, Heidi's already sort of mentioned the 4 areas that we look at, but the marking scheme is equally divided between the person, the research proposal, the site and support, and the training and development. So you need to score well in each of these rather than the research proposal being the most important, although obviously that's the thing we tend to concentrate most on when we're developing fellowship applications. And this is the marking scheme that we use. So essentially, if you are excellent, good, or have minor weaknesses in any area, then you would score a 4, 5, or 6 and be fundable. Whereas if you had moderate weaknesses or worse than that, then you're deemed not to be fundable. And we score for each area, and it's the mean score across those 4 areas that determines whether you go through to interview. So essentially, if your mean score is 4 or higher, then you're deemed fundable and proceed to interview. If your mean score is less than 4, you're deemed unfundable, and the application's rejected at that stage. So what do we look for when we're looking through the applications? Well, I think it's important to say that when we're looking at the person, we're not expecting you all to be beautifully cut and polished diamonds at the time of application. And there's very much a remit that we should also be looking for rough diamonds that are people that can be developed over time. So there isn't a specified minimum number of papers or minimum amount of funding that people need in order to be successful in their application. But if you've spent time in research specific posts, for example, if you're a medic and you've done an ACF post, or if you've done a pre-doctoral fellowship, then obviously we would have greater expectation of you in terms of the number of papers that you've published, and also whether you've achieved funding at all over that time compared to someone who has had very limited research experience otherwise. So we look at your previous research experience and your suitability for a PhD. If you haven't had any research experience, obviously you need to be able to show academically that you've got the suitability to go on and deliver a successful PhD. And as I've mentioned, we look at outputs relative to your experience and career stage. We also look for evidence of your suitability and commitment to a career in research. So what are you saying is your vision for your career over the next 5 or 10 years? Where do you want to be? And as Heidi mentioned, what do you want to be king or queen of? And also your potential to become a leader in healthcare, health and care research. So we're not necessarily looking at just the research component, but what other aspects do you have in your CV? Have you taken on any leadership or management roles? Have you got involved in your specialty area in terms of research collaborations? Have you got involved with your university in any committee? So these other things that add your value in terms of your potential to become a health and social care research leader. Turning to the research proposal, as I've mentioned, reviewers are unlikely to be experts in your clinical area. So it's really important when you write your research proposal that you bear that in mind and don't assume any knowledge when you're writing your proposal. What we look at is it suitable for a PhD? Is it the sort of work that we would expect for a PhD? Is it light? Is there not enough in there? Is there far too much to deliver over 3 years? You're allowed to have started your PhD and be up to a year into your PhD prior to getting a doctoral research fellowship. So if you've done that, what's the quality of the work you've delivered today? Are you on track for a PhD based on that first year of work? And as Heidi mentioned, is the project deliverable in the proposed timeline? So if you get too ambitious, it would raise alarm bells to us as to whether you're actually going to finish that work or not. Is the methodology suitable for the research question? It's amazing how many times we see applications where actually the methodology really doesn't fit the question that's being asked, and that's where getting a good team, getting methodological or clinical trial support, if appropriate, can be really helpful. What's your likely impact? As Heidi said, is this a research priority? Can you put in there, this has been identified as a NICE research priority or a James Lind Alliance research priority, to assure us that actually this is a really important question that's being asked, and therefore it's likely that if you achieve an answer, it's going to impact on patients in clinical care. And what's the quality and scope of the existing evidence? You know, have you reviewed all the existing evidence? Have you interpreted that properly and taken that into account when developing your research proposal? Really importantly, has there been meaningful PPIE? So have you spoken to patients and public representatives? Have you taken their views into account, and have you involved them in the design and the ongoing delivery of your PhD proposal? And we can often see that in the quality of the plain English summary, whether someone's included a PPIE representative in writing that plain English summary. Turning to the site and support, what's the suitability and experience of your supervisory team? So do they have track records of delivering PhDs as supervisors? And are they likely to have adequate supervision time to take you on as well? So whilst it's fantastic that you've got a PhD supervisor who's supervised 6 PhDs to completion, that shows a really good track record. If you put down that your supervisor is supervising 8 other PhDs, that's really going to raise alarm bells for us as to whether they really have adequate time to supervise you as well. And does the team cover the methodological expertise of the project? So again, it's not uncommon for us to find a team where there's aspects or work packages of the project that there isn't someone clearly giving supervision to the methodology to help people deliver that aspect of their PhD. And again, that's something we quite commonly say, we think that you need to go and get a supervisor in methodology X to cover this aspect of your project. What's the track record of the host institutes, both in the research area and in early career development? And I think particularly in Leeds, you know, we're very strong in both of those areas for a lot of the clinical areas that we're supporting PhDs. And what's the evidence of the host in terms of research and EDI culture? So we do look at that supporting statement from the host, and does it have in it, this is our research culture, this is what we're doing for EDI, this is our Athena Swan status, because that's really important in evidencing that research and EDI culture. The training and development is often either slightly neglected or over-ambitious. And it's important to remember that NIHR fellowships are training fellowships. So actually your research proposal is a vehicle for your training rather than us paying to allow you to deliver your research proposal as the primary aim. The research proposal is secondary to allow you to get the training you need to develop as an academic and as a clinician. So what we're looking at are the training activities aligned to the needs of the project. So what we often see is that people go off and do courses because they're doing a feasibility study, for example, and they want to learn about clinical trials for their main study. But actually what they're not doing is courses based on delivering the feasibility study and the other work packages, which have often got perhaps a qualitative work package, and they need to go off and be trained in how to deliver those qualitative aspects. Can you build your network? Can you start to develop yourself as a national leader? Can you start to develop international visits? And international visits are particularly important for the advanced fellowships, maybe less so for PhDs, but can you go and visit centres of excellence and start to deliver that collaboration that you'll need to continue your research trajectory? Don't pack your training and development with conferences. We're not paying for you to go and have a jolly at 7 conferences a year. If you're going to conferences, you need to justify why you're going to them, and ideally trying to tie it into presenting aspects of your research, because although we recognise that it's useful as a network builder, it's not something that goes down well if there's lots and lots of conferences. Will the activities advance you as an individual? And that's both as a clinical practitioner and an academic. And will it support your career intentions? So do think about your wider clinical training. Are there things that you can go and do and learn that align to your research proposal, that will allow you to develop as a clinician? And think about things like leadership and management. Can you go off and do a management or a leadership course that's going to start to allow you to build yourself as an academic leader moving forward? The interview can be quite daunting. There's a large panel and you have a room that is not unlike this. If you're at the doctoral research fellowship interviews, you will be on that big screen at the end. If you're an advanced fellow, you come face to face for interview, but the panels probably consist of around 15 people, and for DRFs there's 3 panels running at any one time. You will have a brief introduction from the panel chair just to welcome you to the interview, and then we'll be asked to give you a 5-minute presentation. I'll cover that shortly. You then have really 3 people who will ask you questions. The first one, your first reviewer, will ask you about your project for 7 to 8 minutes. Your second reviewer will ask primarily about your training plan and career aspirations for 5 minutes, but may also ask you a project question. And then you will have a PPIE representative who asks you about the PPI related to your project. And those questions can actually be some of the most challenging questions to answer, and they can really influence how things are seen. The floor is then opened for any questions any of the rest of the panel may have, if there's time allowing. Your presentation needs to be punchy and it needs to be top level. So we don't need to hear about the detail, but we do need to get an overview of your project, and you need to be able to show enthusiasm for your project. So if you come in, you're enthusiastic about what you're doing and show real passion, that really will rub off to the panel. Please assume most of the panel members probably haven't read your application, certainly not in any detail, and often panel members are skimming through your application as you're giving your presentation. And many won't have any knowledge of your clinical area. So don't assume any knowledge either on the clinical area or on the project itself. You will need to cover the background to the research question and the clinical or methodological need for your research, what your research question is, and an overview of the project work packages as to how you're going to try and answer that, your training plan and your supervisors and how they're going to get you through your PhD or your advanced fellowship, and more importantly, how they're going to propel you to the next level, and what your career goals are and why you want a fellowship. So making it clear of the benefits of a fellowship rather than just project funding. And stick to time, which we're not doing very well in this presentation, but they will cut you off at 5 minutes. In terms of the questions, as I say, the first reviewer will usually have either good knowledge of your clinical area or your methodology, or potentially both. And they will tend to raise questions that have been raised in the peer review around your project, and may have specific personal questions as well. But each peer reviewer is asked to raise questions that need to be clarified at interview. So sometimes that will just be clarifications. Sometimes it will be around choice of methods or the practicalities of delivery of your research. Do you have the appropriate support, as we've mentioned, for each of the work packages? And are you going to be able to stick to timelines? Are they realistic? Your second reviewer will then ask about training questions, and as we've mentioned, that was likely to be around the appropriateness and the breadth of your training. But not uncommonly, we have to ask what could you do without, because people pack their training so much that really there's no time to do their PhD research as well. So it's not uncommon to be asked, if you had to take something out of this, what would you lose? For PPIE, I'd advise you to avoid tokenism. They pick up on it like quick as a flash, and make sure that your PPIE is fully justified and supported, both in terms of time and funding, and support for your PPIE members, and make sure that your PPI team have got diversity and lived experience of your clinical condition. The questions are then opened out to the floor, and there can be various questions, usually questions of clarification that are asked if there's time left, but you need to make sure that your answers are clear and concise, because actually your interview will be over in a flash, and the longer you spend talking, the less opportunity you have for further questions, and therefore you reduce the opportunity that you have to shine. So being to the point and punchy allows more questions, and really allows you to show your expertise. Once the interview is finished, we usually have a brief summary of the application that's given by the lead reviewers, and then all panels score you from 0 to 6 for each domain. So you get a mean score from each panel member, and then you get an overall mean score across the panel, and you need to score an average of 4 or more to be recommended for funding. If there are major corrections that we feel really needs a reapplication, even if you score more than 4, if there's a major project problem, it may be that you're not funded, and it's not uncommon to be recommended for funding with advisories, which are small things that we ask you to change in your application prior to agreeing the funding. You're not competing with anyone else other than yourself, so all those meeting the level recommended for funding are put forward to the Department of Health and Social Care for approval. So it's not that we have a minimum or a maximum number of people who will be recommended for funding. It's very much based on whether you meet that threshold. And funding panels want to support applicants and projects, so we really want to bring on the next generation and give you the opportunity. So we're not looking for opportunities not to fund you. We really want to help and support people get through and be able to get their PhD or their advanced fellowship and progress their clinical academic careers. And with that, I think we're done. So thank you very much for your time, and we'd be happy to have any questions.
Thank you so much, both Heidi and Dave, for enlightening us with the top tips how to prepare for application, and also some fantastic insights from the perspective of the committee. Certainly, we learn and we are inspired by your clinical academic journey. One using the clinical academic training, and one using clinical pathways, and then going to the academic yourself. So we're just gonna open now for questions. So we got one question already on the chat. So in the DRF process, do you get feedback from the peer review prior to the interview?
No. So it's all done. It's all done as an internal process, and that peer review, as I've mentioned, partly drives the questions that you're asked at interview, but there's no feedback. If you're successful, you get invited to interview. If you're not successful, then obviously you're not invited to interview, but are given feedback from the peer review if you're unsuccessful.
Okay, thank you. I just want to ask a question, because I think there's no question at the moment yet. Pertaining to a host statement, sometimes this is one of the aspects that people tend to leave it at the end, which is, you shouldn't really be doing that, because it is really a key thing in your application. How, what's your advice in terms of preparation, and what do you look out for when you're marking, this section?
Yeah, certainly the host statements, we see some amazing ones, and we see some ones that you think, do they actually know the person that they're supporting? So that's probably one of the big things that needs to come across, is that it's actually personalised, because somewhere like Leeds, we support lots of applications, and so there is a template that we use, that sort of says, gives lots of the facts about the University of Leeds, and particularly like sort of Faculty of Medicine and Health. But it needs personalising, and that's where it's really important to ensure that you're actually working with the person who's going to sign that off, who's going to upload that statement to ensure. And now, certainly, when we see, obviously we talked about the University of Leeds and Leeds Teaching Hospitals having a very close relationship. So, lots of the work that's done, lots of the strategies that are in place to support early career researchers are across both organisations. But as we look to support smaller organisations, so for example, the University of Leeds with some of our other trusts locally, you want to see that integration between the two organisations. And sometimes, that can be very obvious when you don't see that. You see sort of two parts to the host statement, and they're not joined up at all. But ultimately, even if you aren't working with your partner NHS organisation, or your NHS working with the partner university that they typically work with, you still need to see that collaboration and that joint support for the host. So yeah, my two sort of tips would be to ensure it's personalised, and that actually there is the collaboration and integration between the two organisations that are supporting you, the two things that stand out most of all.
Okay. Thank you, Heidi. So we've got a few other questions, because our audience are wide range, from pre-application to post. So there's some questions about HTA. So what factors make a researcher-initiated application, like, for example, HTA, successful?
Do you want me to take that? So I think with the HTA, the first thing to say is there are two ways of looking at getting your research funded by the HTA. So there is a prioritization committee that you can put applications into to suggest research that they may commission. The benefit of doing that is that if NIHR decide they're going to commission that, and you'll see that coming out as commission calls, that means that really they've committed to funding that topic area. The downside of that is there's no guarantee it'll be your application that gets that money, but obviously that's one way, and particularly if you're working with a national team or you're a lead in a certain area, then that's a really good way of doing things. And it's very common actually that the team that wins the commission call is the team that's done all the development work, because they're the team that are in the strongest position nationally to put that application in. I think the really crucial things, if you're looking for an HTA researcher-led trial, is you have to show that it's a valid research question and it's a priority. So if you can link that in to national research priorities, as we've mentioned, the James Lind Alliance or NICE research questions that come out of guidelines, or guidelines that or questions that are generated from other guidelines, then you're in a much better position to demonstrate that it's a really important question. The HTA are looking ideally for sort of more novel and cost efficient ways of delivering trials. So having designs that are reduce waste, reduce patient visits if you're able to collect data from routinely collected NHS data rather than patients having to come specifically for visits, for example. Making sure that you've got a really strong team around you. So if you can build a sort of multidisciplinary team of national experts, then that puts you in a strong position as well. So I think it's a combination of all of those factors that they look at. But you know, the HTA is really competitive, sadly. So and you'll often hear that people who get HTA grants and have successful HTA projects, the most successful, most impactful projects are often 10 years in the making. So it's, you know, 10 years from coming up with an idea to actually getting to the point of putting in a successful HTA application.
I understand there's a call now for an advanced fellowship with HTA within it. It's a new call, so we don't have any experience of that, but the combination of those two sounds quite exciting to me.
Yeah, so both EME and HTA, yeah, advanced fellowship things.
Okay, if it's possible, we just have one last quick question. So I think 2 weeks ago we had a talk about funding opportunities. I think we know that the NIHRs, and for example, that the streams all join now. We have the pre-application, doctoral and the postdoctoral. So the question was about, so do the streams diverge at review and interview stage again?
So, for example, with the doctoral fellowship, the applicant will submit a doctoral fellowship application, and it will be NIHR at the sort of reviewing the remit of the application will decide whether it goes to what was original or sort of what is currently the doctoral research fellowship panel for all disciplines, or whether it will go to the integrated clinical academic pathway, the ICA pathway, which is the the doctoral clinical academic fellowship, the DCAF, or the social care equivalent. So it's actually at the sort of remit checking level that they will decide which panel that goes to. So, for example, historically, you could have applied to the doctoral and to the DCAF panel separately, but now you can't do that. You just apply to the doctoral fellowships award scheme.
Right, okay. So I think we are going to close the meeting now. So I would like to thank Heidi and Dave again for enlightening us about how to prepare a successful application. And thank you everyone for attending the session today. So we will send email around with a feedback survey form again. And I hope you all have a nice day. Okay, bye-bye.
Thank you.
Thank you.